every one of us has been in the hospital and hears the incessant noise and the beeps constantly. And if you've ever been in the hospital as a patient or a caregiver, those times when a provider walks in while the bedside monitor is alarming and hits silent and walks out. Right. And you're sitting there as a patient or a caregiver thinking, wait, that noise was supposed to alert you that something's happening. And you look at the provider and say, no, don't worry, that's nothing. 90% of patient-generated bedside alarms are what are called non-actionable, meaning nobody does anything about that. Non-actionable alarms, by in turn, therefore lead to patient safety issues because when nobody believes the noises, the important ones are ignored.
Welcome to Boombastic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change.
Well, good afternoon. Live at ViVE, another edition of the Boombastic Health Podcast, and it's have the pleasure and honor of my good friend, Dr. Darren Klugman. Darren, how are you?
Great. Thanks for having me. Really
Awesome.
Excited to be here.
Yeah, it's so great having you. And Darren and I went to undergrad together, and excited really to kind of talk about our healthcare journeys and what we're seeing today. So first, Darren, kind of tell us about what you're doing at CalmWave.
Sure, absolutely. So I'm the Chief Clinical Officer at CalmWave, and we are a patient safety and hospital operations platform where we bring together historically siloed data sets from the electronic health record and the bedside middleware, which is all of the patient vital data, all of the hardware that's fed into the bedside monitor, into a unified, structured, normalized, and de-identified cloud-based data storage platform. We then use that data to improve patient care and reduce patient harm, and ultimately have data-informed hospital operations so that everything is streamlined from nursing, staffing, clinical engineering, and ultimately now we're rolling out our newest use of this data set, which is forecasting patient recovery.
That's great to hear. At ViVE, there's just a lot around data and safety and interoperability, but what you don't often hear about is patient safety. Right. So it's a very unique angle. And as a practicing clinician, maybe from your perspective, what do you kind of, through that lens, how do you see AI really being able to accelerate how we take care of patients within the four walls of the hospital?
Well, I think there's two things I'd like to point out. The first is a story. Every one of us has been in a hospital and hears the incessant noise and the beeps constantly. And if you've ever been in the hospital as a patient or a caregiver, those times when a provider walks in while the bedside monitor is alarming and hits silent and walks out. Right. And you're sitting there as a patient or a caregiver thinking, wait, that noise was supposed to alert you that something's happening. And you look at the provider and say, I'm sorry, Dr. Gordon. And you're like, oh, no, don't worry, that's nothing. 90% of patient-generated bedside alarms are what are called non-actionable, meaning nobody does anything about that. Non-actionable alarms, by in turn, therefore lead to patient safety issues because when nobody believes the noises, the important ones are ignored.
Right.
And that's what we're tackling. But as you said, we shouldn't tackle problems in silos. We have data.
Yeah.
The problem with healthcare is that many people are unaware of what data we have. And so we are very dogmatic and live in a world that this is all how we've always done it.
Right.
So why is it that we should have a massive data set in the EHR and a massive data set that is significantly bigger than the EHR from the patient and not bring those together to inform care?
Yeah.
So you're 100% right. It should be data-informed care delivery, and there should be a role for AI. What we do is math and data science. So we apply mathematical modeling and data science to this huge data set. So it's not an LLM wrap on data that you can get off the shelf in Claude or Anthropic. This is real deep data science. I think one of the other things I'd say to your question is the following, which is that all of the data we have has eclipsed the human capacity to analyze it.
Right.
Patients are more complicated. Care is more complicated. There's more and more devices integrated into the care delivery. And as that has expanded, we keep saying to providers, utilize this new data element. Here's a new score that's going to help you predict. The providers can't utilize what they're seeing now.
Right.
So one of the fundamental things that we do at CalmWave is we say, we're going to take the data, structure and normalize it, and then apply mathematical modeling data science to deliver you recommendations, you can then decide to use it or not. But what we don't want you doing is using cognitive time to think about things that you shouldn't have to think about.
Yeah. I think that's it's always been one of the biggest barriers to technology adoption in the provider environment, right? As a provider, you're certainly keenly aware of that. Often there's been technology there, but how do we use it effectively? How do we get it within the workflow? How does it augment what we're doing? And, we like to talk about it with our agentic AI platform as kind of human in the loop.
Yes.
But what you're helping to do is actually go one step beyond that and say, okay, we're going to have your human, but your human is that AI agent that you can trust and that verifies that. So then that next level, that task that you might have normally had to do, you don't have to do. You can trust us to help you go move on to your next task and move through your patient queue more effectively.
And
right?
all of those things are true, right?
Yeah.
And what we believe is that if you as a health system believe that you've hired the best and brightest to do this work, we should empower them to make these decisions. And we should want them practicing at the top of their degrees and spending the time thinking about things that really require their expertise. So for example, bedside patient monitoring and alarm adjustments. Why should it change dependent upon who the provider is at the bedside? Why should it be a one-size-fits-all solution?
Right.
It shouldn't. And we have the data to inform those parameters rather than making it subjective. And by the way, this is not cognition that people should use. They should be touching the patient, talking to the families, analyzing the data, and how patients are monitored most safely should be automated and should be data-driven.
And I think, too, it doesn't only have impact directly on, the patient care that's being delivered at that moment in time. You have patient sat and all these other things that, are factors, right? And how hospitals get paid, how patients view the provider or the care delivery team that they're interacting with. So it's such an important part of the equation, right? In that acute care environment that often gets overlooked.
And on the other side of it, from the system side, we can't assume that systems are going to pay for 80 different solutions that are peripheral to a particular problem. And so what we have built is a single data set that is the foundation for our hospital operations. So our data set gets you improved patient safety, improved data-informed care, and a platform for clinical engineering to see real-time visibility into device performance. Is there an alarm going off on the bedside monitor, on the ventilator? Historically, they've never gotten that. It's all from me calling and saying, hey, this ventilator doesn't work. Can you please come here? Now we give clinical engineering real-time visibility into those alarms. They can show up and say, Marcus, your ventilator is not working properly as an alarm. We're going to take it and give you a new one. We give it to nursing. Nursing can utilize this data to inform nursing staffing. And ultimately now with patient recovery, we're looking at mathematical modeling and data to understand when patients are ready to either discharge from an ICU, step down unit. We can right-size bed utilization, accelerate patient throughput, and ultimately optimize revenue and reduce patient exposure to harm by being in a bed that they don't need to be in.
So within that framework, what are the top 2 or 3 ROI metrics that you focus on, or you're seeing your providers coming to you or health systems coming to you to really kind of acutely look at?
All right. So I think there's 2, right? The first is we focus, as I said over and over again, on patient safety and operations, right? So by using data to inform these decisions, we're making care safer. By making care safer and reducing harm, you're immediately getting patients through the system more quickly. And ultimately, our patient recovery platform is going to allow systems to get patients out of ICUs quicker. And we know that every day you're in an ICU, 2 things happen that the public isn't aware about. Your IQ points are reduced and you're exposed to harm. So getting patients out of the ICU is very good for patients. And ultimately, we're in a business. And what hospital systems want is they want optimal bed utilization and patient throughput. And our data stack now informs that. So we can help hospital systems get patients through much more quickly.
Yeah.
And that does two things. It reduces length of stay and increases revenue by allowing improved bed utilization.
Well, thanks for very clearly articulating that. And I think when we think about the value prop, right, we're here at ViVE, and there are literally hundreds of companies that are talking about value props. You have a very clear, articulate story. And as you sit on the practitioner side, but you also sit on the business side selling into practitioners. So what have you seen, and maybe what's some of your advice and guidance? And our audience is, health systems, providers, entrepreneurs, executives. So we have an entire suite of people who sit on both sides of the coin. What does that look like from your lens relative to a business trying to sell into a hospital system? And then for those executives at a hospital system buying this pertinent technology across their entire suite, what should they be looking at?
I think there's a couple of things. I think number one is we have to embrace the time that we're in, right?
Yeah.
The time that we're in is one where the utilization of data is unlike it's ever been before. And we should maximize that potential, right? So in doing that, I think there are fundamental things that we need to understand. We should not be asking the bedside providers to interpret additional data than they already have. They can't use what they have. So we need to make the data actionable, and we need to make it relevant rather than giving them additional data to interpret.
Yeah.
I think the second thing is what we are really focused on is providing a single solution for these systems across different care paradigms. So our system is very well designed for single ICU care.
Right.
It's exceptionally well designed for remote ICU monitoring because everything starts with full visibility of the ICU, and we have different lenses. You can see the patient lens and the ICU on a unit level, on a hospital level, on a system level, right? So as vendors, we need to provide solutions that offer a lot of value across an entire care delivery spectrum, right? That's our responsibility. On the terms of the health systems, they are now inundated with everywhere they turn, there's another solution, right? And I think it's incumbent upon them to understand where the ROI sits and how their data is being utilized in order to really inform care. And as I said before, it's a business, and there's a way to do this together. And I think that's what we're really excited about, is how we have been able to take this data-driven approach to really inform care across the spectrum. I think that's at the end of the day what we're all going to have to answer for.
Yeah.
We can't have a million point solutions for one problem. It's not going to work.
Yeah, we agree. I mean, at HC1, we built an agentic longitudinal platform, really with the lens through the lab that I think ultimately, if you take and you piece together these longitudinal pieces, whether it sits within an ICU or a lab or another piece of the hospital, and you're able to put them together effectively and generate that ROI use case, I think, there's unlimited potential. And it's all about, accelerating patient care, right? And reducing the burden on the providers, and enabling, all the practitioners to practice up at top of their license, and for this to get better. I mean, really, that's, it's incredible, but it's all about, making the system better for everyone.
Yeah, and it's that old adage, never let a good crisis go to waste. And I think we're all seeing it. We're in the midst of a healthcare crisis. We're not growing new nurses. We're not growing new physicians. In fact, they're leaving at a rate unlike we've ever seen before.
Yeah.
And we're not getting more beds, right? And as the care delivery environment shrinks and rural hospitals are closing, it's incumbent upon all of us to make sure that access to care remains the same, and the quality of care, as you said, really should be elevated, and that's the goal here. Right?
Absolutely. Great. Well, Dr. Klugman, thank you so much for sharing your insights today, and continued success to you and the team. We'll be in touch.
Thanks a lot.
All right. Thank you.
Appreciate the time.
Okay. Thanks.